Welcome everyone to today's webinar, How to Optimize COVID-19 Vaccine Administration with AI and Automation. I'm Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Ezekiel Emanuel is the Vice Provost for Global Initiatives and Co-Director of the Healthcare Transformation Institute at the University of Pennsylvania. He is also the Special Advisor to the Director General of the World Health Organization and a member of President-elect Biden's COVID-19 Transition Task Force. From January 2009 to January 2011, Dr. Emanuel served as a Special Advisor on Health Policy to the Director of the Office of Management and Budget and National Economic Council. Dr. Emanuel also serves as a venture partner at Oak HCFT, in addition to serving as a contributor for the New York Times and CNN. He has published over 300 articles, mainly on healthcare reform, research ethics, and end-of-life care, and has also authored or edited 13 books. Mutu Alagathan is a board-certified physician and engineer who serves as the medical director at Notable Health and an attending physician at UCFF. Previously, Dr. Alagathan was a hospitalist at Massachusetts General Hospital, a faculty member at Harvard Medical School, and a research collaborator with the MIT Media Lab. For his contributions to data science and artificial intelligence, he has twice been recognized as one of Forbes 30 Under 30 and has been invited to speak at South by Southwest and TEDx. Dr. Alagathan received his bachelor's degree in biomechanical engineering from Stanford University and MD from Stanford School of Medicine, where he was a Soros Fellowship finalist.
Dr. Emanuel, I want to begin by thanking you for spending time with us today. As one of the foremost national experts in health policy and a member of the Biden-Harris Transition COVID-19 Advisory Board, you've helped tackle some of the most difficult ethical and public health challenges that our country has ever faced. So we thank you for those contributions and for engaging in this conversation about technology and the COVID-19 vaccine distribution.
Great, good to be here. It is certainly true that the pandemic has thrown up a number of challenges that the country hasn't faced before.
So I'd love to begin our conversation with a focus on health systems. So the health systems of this country are the pillars of clinical expertise and experience, yet almost none of them have ever faced a pandemic of this magnitude or a vaccine distribution of this complexity. In your opinion, what are the unique operational challenges that health systems will face with the administration of the COVID-19 vaccine?
Well, you're 100% right. I mean, this pandemic has challenged them with lots of patience, how to actually maximize things like PPE, beds, and the cycles are incredibly intense and rapid. There's been not just supply of beds, supply of equipment and supplies like PPE, but there's also staffing and getting all of that mixture to work. And during an intense period has been an unbelievable challenge. And now we're going to add vaccine distribution to that. And not just vaccinating the healthcare workers they have, but there will be a role to play in terms of vaccinating the larger community. How much that falls on health systems, how much it falls on other parts of the healthcare system, I think still needs to be determined. But even doing just the healthcare workers in a healthcare facility and in other facilities is obviously also a big challenge, in making sure that the people who are actually caring for the patients day in and day out get to the top of the list. All of these are major challenges.
Great. You know, depending on the day and the poll you look at, anywhere between 15 and 40% of individuals say they either probably or definitely do not want to receive the vaccine. Are there patient populations that you anticipate will be specifically harder to ensure vaccination for?
There is no doubt that the public's willingness to take the vaccine changes. It changes based upon what's happening in the media. It changes upon perception. It also changes on who they're listening to and the messages that they're getting. I like to think of four groups of patients. There's the early adopters. I would suspect many of the people listening to this are probably in the early adopter group. I'm certainly in the early adopter group. I look at the data of the unbelievable effectiveness, the minor side effects, and the risks on the other side of actually getting COVID-19 and getting a potentially severe case. The vaccine seems like a great deal. At the other extreme are people who are against all vaccines, view them as wrong in some way, either very unsafe, unnatural, or something else. We tend to call them anti-vaxxers, but I think that they're an incredibly small group. Those dedicated, they're not taking any vaccine, and COVID vaccine is just one among many. They're probably, they're definitely 5% or less of the population. And then there's a big middle that really is two groups. One is sort of, they're coming after the early adopters. They're inclined to take vaccines. They take flu vaccines and other things, but they're a little hesitant with all the information swirling around this vaccine. The speed makes them a little nervous. And then there are people who are, you might say, hesitant, and they're a little more, have said in polls they're not going to take it, but I think are moving. And we're seeing, I think, a steady increase in the number of people willing to take the vaccine as they've seen the rollout, as they've seen the fact that there have been no major problems with it. There have been a few anaphylactic cases, but no major problems. And as more and more information comes out about the vaccine and also about just the alternative of actually getting COVID. In the end, I think we're going to get the vast majority of Americans. But along the way, there are going to be challenges. One challenge consistently in the polls is minorities, and particularly Black Americans, hesitant about getting the vaccine. There are many sources of this hesitancy. One of them is clearly a very, very antagonistic relationship with healthcare systems. The fact that many Black Americans have not been treated well over the years and have had a hesitation about being used by the system in cases that are not to promote their own health. And that distrust of healthcare has fallen or spread into distrust of things like vaccines. It's going to require a special communications and outreach effort to get those kinds of communities involved. But I should say that's not the only community, and attitudes are not the only barrier. Remember, we're going to be vaccinating in phases. It's not like we have vaccine available and anyone who walks into a CVS can get a vaccine. Initially, it's healthcare workers and those people in long-term care facilities. Then the Advisory Committee on Immunization Practices, ACIP, has recently said that the next group ought to be essential workers and people, Americans over 75. Well, that presents a big challenge. Are they giving it to people over 75? Where do I go to get it? Am I in that group? How will I know when they're going to begin to give it to this new group? Am I an essential worker? Who qualifies as an essential worker? I'm a university professor. When they say teachers, does that include university professors, or is that just elementary school or secondary school? Does it include daycare providers? Similarly with other essential workers who are on that list, first responders, grocery store workers. So I think educating those people, we're now getting to your tier of people. Here's who's in that tier. Here's where you get it. Here's the website where you sign on. I think all of those are major logistical challenges that are going to require major outreach efforts and communication strategies. And that's going to have to fold into, people's busy lives, trying to figure out what they're doing, and working hard, juggling things like, caring for their family, educating their kids, going to work. So I think those kinds of challenges are present for the healthcare system in trying to get the vaccine out, and they're going to be a major issue.
Very insightful. And you mentioned a couple, several challenges in there, everything from specific patient, subpopulations to the logistical challenges of just notifying patients and educating them. Is there any parallel that we can look at in terms of a health policy or a healthcare challenge that systems have faced in the past that's similar to this one, either in terms of scope or complexity, or is this new territory?
I think this is pretty much at the far extreme of the complexity that we are facing and the challenges necessary. We haven't even layered on the problem that it's very likely that different states are going to have different priority groups. While the Advisory Committee for Immunization Policy has made a recommendation, not every state is necessarily going to follow that recommendation. So we've already heard, for example, that Texas plans to in the next tranche after the healthcare workers to immunize all people over 65 rather than essential workers. That cacophony is going to further complicate the logistical and communication issue. And I think, different healthcare systems are going to have to respond to the local environment and different state policies. And, let's add on to that complexity. Which vaccine are you distributing? Does it require 2 shots? If Johnson & Johnson gets approved, call it, mid-February and it's only 1 shot. Communicating all this information to people and making sure that we're tracking everyone. Major challenges.
Yeah. You mentioned a couple of specific patient groups, African Americans and those over the age of 65, and some of the both distrust and challenges in communication there. How do you think, health systems can best engage these, populations that have historically either been distrustful of the healthcare system or in the case of older Americans have maybe been harder to reach with technology? And, what are the techniques you think health systems can use to engage with those types of groups?
Well, so there are really at least 3 groups to think about. As you mentioned, older Americans, people over 75, and then it'll be people 65 to 74. There are minority groups that are very important to reach out. And then there are people with comorbidities who are at higher risk of both getting COVID and getting severe cases of COVID, people with obesity and diabetes and heart disease and respiratory illnesses, immunocompromised people. So all of those have to be identified. And I think, in the past, health systems have been, you might say, passive. Patients come into the system. This is going to require us to be proactive. We're going to have to identify people and reach out to them and reach out in a manner that is going to make them receptive to hearing the message. So, one of the key things about communication is hearing from your personal doctor or a nurse hearing from someone who's like you. So I'm more likely to hear a message or take it on board and listen to it if it's someone who's like me, I can trust. They've got a similar life experience. So having minorities reach out to fellow minorities. In the case of people who've, you might say, been marginalized, a lot of health systems have successfully used community healthcare workers. And again, these are people who are skilled. I mean, one of their key skills is to actually reach out and be empathetic and draw out people who feel like they've been excluded from the system, may not trust the system, may not access it in the best way. So I think one thing that's going to have to change is, in general, our systems have been reactive to patients coming in. And now we have to be much more proactive in reaching out to patients at the appropriate time with information that they can act on in ways that they can trust the information they're getting. And that is, as you know more as well as I do, that's occurring in a milieu where there's a lot of mistrust of information, there's a lot of misinformation, and so I think there's maybe a heightened level of skepticism. So being able to reach out, be authoritative, and reassure people that what you're saying is something they can trust, act on, is going to be important. So I think figuring out all the different mechanisms of who do we have to reach out to now? What are the best channels to reaching out to them? How do we proactively go about it? And I'm always reminded in these kind of communication exercises, a line which, as far as I know, has been attributed to Richard Nixon, and he was talking about politics, but I think it applies just as well to this issue of vaccines. He used to say, you say it once, you say it twice, you say it 7, 8 times, you are sick of saying it, they're just beginning to hear it. And I think that's a very crucial message. We can't reach out once and, call it a day. We did our part. This is going to take multiple efforts of reaching out in multiple different channels to people to get them to work and to get them to understand what they need to do and to really follow through. And so I think that, just an enormous communications logistical challenge. And we haven't even talked about once you've got them, then actually administering vaccinations, following up with them. That's going to be another major challenge.
I love that quote and that insight. It makes me wonder if we build a muscle in terms of how to communicate and reach out to these populations with the vaccine. Do you think that carries over to how we can be proactive with reaching out for other health maintenance gaps in the future beyond the vaccine? People who are, due for a mammogram or a colonoscopy or just haven't seen their doctor in a couple of years. Is this going to carry over and help us get better at those things as well?
Well, it's a big if. It's easier for me to say, should it carry over? The answer is yes. For the last 5 or 6 years, I've been pounding away at arguing that the high quality system really has to be proactive and not reactive. And part of that being proactive is, as you say, reach out for routine preventative services, but also reach out in terms of educating people about their disease, educating them what they need to do for self-management of chronic illnesses, making sure that they and their family are aware of issues, and making sure that you, as a healthcare provider, are in tune with them, understand what challenges they're facing, maybe to adhering to their medical regimen, so that you can intervene before it gets to be a serious condition. This proactive element, again, it's not something that the system was built on. It's something that the system has to now incorporate it into its DNA. And I do think that the pandemic can give us experience with being much more proactive, and hopefully make it much more integral part of routine care.
Yeah, that's great. I think we have time for one more question, and it's one about technology. And it's been undeniable that in almost every industry, technology has surged in prevalence due to the pandemic, and healthcare has been no different. In the first stage of the pandemic, we saw record utilization of telehealth. We saw unique applications like contact tracing, digital check-in, digital arrival. As we move toward the vaccination stage of the pandemic, I'm curious, what role do you see technology playing in supporting vaccine administration?
Well, it's absolutely critical. I mean, at stage 1, it's analytics, identifying, as we talked about, the patients who are going to be eligible for a vaccine. Being able to follow up with them, register them, making sure we have the information about them, and being able to pass it on to the local, state, and federal health groups who are monitoring the reach of the vaccine. So those are all going to be absolutely critical. Also, obviously, monitoring supplies, making sure that that information is back in the electronic health record so that the providers actually understand what's happened, which patients have gotten vaccinated, which patients have had COVID, being able to follow their course. So I think having the information is absolutely critical, especially if it will turn out that a lot of the vaccination will occur outside the healthcare system, maybe at a CVS, maybe at other mobile facilities that are set up. Making sure that information gets back into the electronic health record is going to be absolutely critical, and I see no way of doing that except through technology.
Yeah, fantastic. Well, we certainly agree. But, this conversation has just been so illuminating and insightful, and want to be mindful of your time as well. So Dr. Emanuel, thank you again for your contributions, as well as for your time today. It's been an absolute pleasure, and we look forward to hearing more updates from you and others in the weeks ahead. So thank you.
Thank you. It's been a great pleasure, and I hope everyone stays safe. It's going to be a rocky ride, but I do believe 2021, after about February, it's going to get progressively better as more people get vaccinated, and we can see the other end of this pandemic.
Yeah, I love to hear that. Thank you again. Thank you all for joining us today on this webinar. I am very excited to talk to all of you about notable and intelligent automation. It was a great interview with Dr. Emanuel just now, and there's two things he mentioned in particular which I think were particularly interesting. One was how health systems need to transform from being reactive to proactive. And second is how can we use technology to help with some of the operational challenges that we'll face as we're distributing the vaccine. And we'll try to cover both of those topics in detail today and how that ties in with the intelligent automation platform of Notable. So Notable Health is an intelligent automation company that is partnered with leading health systems to digitize and automate healthcare. Notable is encompassed by proven technology leaders who in prior lives have built products that are now used by millions. And as a company, we're partnered with 3 of the top 15 health systems in the United States. We've listed 6 of our customers here, but there's many more that we're very fortunate to be partnered with. And then on the far right, you'll see our impact, which we're extremely proud of. So our automation solutions for health systems help save 1,000 plus hours per provider per year, help generate hundreds of new visits for providers every year for types of care that patients are due for. We have a patient satisfaction rating of 97% and a provider net promoter score or NPS score of 74. At the highest level, Notable has created an intelligent automation platform. So what is intelligent automation? Now, we think about intelligent automation in a simple 3-step process, starting with scan, then perform, and then update. So we train a fleet of digital assistants, which we call bots, to perform these 3 steps within an EHR or system of record 24 hours a day. The first step is scan, where our digital assistants essentially scan and monitor the EHR looking for particular patients that match a set of criteria. When it finds that particular patient, it then performs some task. Now, this task can be anything related to the front desk all the way to the back office, but it's essentially any manual task that a human being performs in that system right now. So it could be collecting a copayment, it could be writing a note or adding a billing code to a particular encounter. Once the digital assistant performs the task, the third step is update, where it then actually goes into the system of record using robotic process automation, or RPA, to integrate seamlessly with the system of record and make sure it's always up to date. Using this 3-step process, there are a limitless number of automation opportunities that Notable is able to power for a health system that exist throughout the care continuum, ranging from registration and outreach all the way to provider note writing and order entry, to even manual tasks in the revenue cycle. Now, we'll focus for this example just on a few of those manual processes that encompass the front desk or the waiting room of a clinic. So again, a simple 3-step process that the digital assistants follow. They first scan looking for patients with an upcoming appointment within the next 48 hours. So the digital assistant actually logs into the EHR, reviews the provider's calendar, and identifies the patients who have an appointment upcoming within 48 hours. From there, it performs a task, and in this case, the task it's performing is personalizing a set of digital and mobile intakes for the patient based on what that patient needs to do when they come in. So this could be many of the examples shown here. It could be updating the demographics, collecting payment or an insurance card, confirming a pharmacy or reconciling medications, to performing a clinical intake or collecting a consent form. So all of these tasks that human beings in the front desk would have been burdened with, we've been able to create digital experiences for them, put them in the mobile phones of patients, and allow them to complete it from the convenience of their own home. Once the patient completes these processes, the digital assistant then takes the information and actually updates the EHR in a way that makes sure that system of record is always kept up to date. You'll see our impact on the far right. Again, our patient satisfaction rating has been 97%, with patients continuously telling us how fast, easy, simple, and delightful this process was. Our pre-visit registration participation rate has been upwards of 80% in many clinics, and on average between 65 and 70%, meaning it's only a minority of patients who don't complete the process digitally. And we're able to save about 572 front desk and medical assistant hours per provider per year. Now, bringing the focus to the COVID-19 vaccine and pandemic, we can use the same three-step process of scan, perform, and update to help augment and offload health systems of performing many manual tasks such as assessing risk, educating patients, routing patients to the appropriate care, and automating vaccine distribution workflows. We'll focus on just one of these for now, which is how can we use automation and intelligent automation, this simple three-step process to assess the risk of COVID-19. And here's how we've done it. We started this work early in the pandemic, and we trained digital assistants to identify patients who had an upcoming clinic appointment, to reach out to those patients 2 days before their visit, and actually ask them a set of screening questions to assess their risk for COVID-19. We then trained the digital assistant to help triage these patients to the appropriate site of care. So in this example, if the patient told us that they had a fever, shortness of breath, and a fever to 101, we would actually know to tell them that they may have an upper respiratory tract infection and that they shouldn't come in for a scheduled visit, and instead they should be set up for a telehealth visit. We're also able to educate patients in this way by giving them just-in-time reminders and best practices for how to stay safe. But we can actually go one step further and use that digital automated HPI, or history of present illness, for the provider. So the blue box you see on the right is a history of present illness that was written purely with machine intelligence and natural language processing. There was no human being involved there. But using the same three-step process, we've been able to outreach to these patients, triage them, and offload provider documentation burden. We've done this at quite a large scale. We've sent over 280,000 of these COVID-19 outreaches across many states and hundreds of clinics. We've helped redirect over 3,400 patients away from in-person care who may be at high risk for COVID-19. We've done it with a remarkable 97% patient satisfaction, and probably even more remarkably, an average deployment speed of 4 weeks or less. You'll see some of the patient perspectives on the right. Patients have loved not having to hold a clipboard and share a pen in the waiting room, but rather answer these questions in a simple and easy to use manner before the visit. But I want to shift the focus now to the newest stage of the pandemic, which is the vaccine distribution and administration. As Dr. Emanuel mentioned, there are going to be many operational and logistical challenges related to the vaccine administration the health systems will face. In many of our conversations with our biggest customers, we've heard the following 4 themes repeatedly. 1, how do you ensure that your highest risk patients receive the COVID-19 vaccine at a designated administration center, especially patients who live in long-term care facilities or may be harder to reach otherwise? 2nd, how do you ask patients the appropriate pre-vaccine questions, such as whether or not they're pregnant or immunocompromised, and whether or not they've ever tested positive for COVID-19 in the past, and whether they've ever had a serious reaction to a vaccine in the past? Third, how do you educate patients on when and where to receive the second dose and to remind them to return for their second dose when it's time? And then fourth, how do you make sure that these vaccine administration records get stored in the EHR in a way that allows providers to know which their patients have and haven't been vaccinated yet? So what we'll show you in the next slides is how Notable's intelligent automation platform can help power and automate much of this vaccine workflow in a way that really enables health systems to vaccinate their populations in a large and effective manner. So we'll start with a fictitious patient scenario. So this is John Smith. He's a 72-year-old male with type 2 diabetes, COPD on home oxygen, no prior history of COVID-19, who currently resides at a skilled nursing facility after a recent discharge. He's been lost to primary care follow-up for the last 18 months. Here on this slide, you'll see the automated workflow that we've designed to help health systems vaccinate patients like John Smith. We'll walk through each step of this slide in more detail in the coming slides, but wanted to give you a high-level picture of how much of this process that Notable can automate for patients like John. So the first thing the digital assistant will do is it'll scan the EHR to identify unvaccinated patients. Again, using robotic process automation, we have the ability to teach the digital assistant to navigate a computer screen the same way a human being does, and to both read and write information. From there, the digital assistant is going to engage with the patient via an automated text message or email. From there, it can work with the patient to digitally update any demographics and perform any clinical intake forms or questions, such as the last time they received any vaccine or any prior allergic reactions. Using its built-in intelligence, it can actually triage the patient as either high or low risk. And as we learn more about what these criteria are, we can configure the intelligence to match the latest recommendations. For high-risk patients, the digital assistant can then collect a consent form and any administration, insurance, or payments if necessary. It can update the EHR with those details, but then also help route the patients to the appropriate vaccine sites, as well as remind them before their second dose. And then finally, it can perform an automated check-in with the patient at any time point after the second dose to make sure the patient is doing well and not having any adverse reactions. But I do want to step into this flow in more detail. So we start with the first step of the process, which is identifying and engaging eligible patients. So we've trained the digital assistant to scan the EHR, identify unvaccinated patients like John Smith, and then automate an outreach to these patients via text message. You'll see that on the right, where we can configure a white labeled experience text message coming from your clinic, letting the patient know that their own provider wants them to complete the following intake. From there, we can let patients like John Smith know that we think they're in a high-risk category for COVID-19 and would benefit from receiving the vaccine. We can also provide any education or information that would help patients like John Smith make the decision to get vaccinated. From there, we can ask the patient a simple question of whether or not they're interested in receiving the vaccine, and we can have a dynamic response to that question that follows. If patients like John Smith tell us that yes, they are interested in receiving the vaccine, we can then allow them to continue forward in answering a few more questions like you see on the left. If John Smith tells us that he's not interested in receiving the vaccine, we can actually probe further to understand why, transfer that into structured data, and help the health system improve its communication going forward. Now, if John Smith was in fact interested, we can then move forward with collecting a consent form digitally, like you see on the far left, helping schedule an appointment for the vaccine if the health system is using appointments to administer the vaccine. And then we can also do automated pre-visit screening. So when it is time for the vaccine, we can send John Smith another text message right before the actual vaccine administration appointment, asking him to answer a few questions about his current symptoms, ensuring that he's never had a serious allergic reaction to a vaccine before, or making sure that he's not actively acutely ill. From there, we can automatically update the EHR records after the vaccine using our digital assistant's ability to interact with the EHR using robotic process automation. So you'll see on this slide, we started with scanning and identifying the patients, then performing the task of engaging with the patient, collecting a consent, asking questions, And then on the far right, you'll see the font's quite small, but the bot, the digital assistant's actually writing in the HPI independent note in Cerner for the provider. It can also update discrete data fields in Cerner, Epic, or any other EHR with the appropriate vaccination information. From there, we can automate the follow-up to patients to ensure they receive their second dose. We know the vaccine is much less effective, at least the current vaccines are much less effective without receiving a second dose. So right when it's time to receive that second dose, we can automate a text message to the patients, letting them know that they're due for a second dose of the vaccine and that it's important that they receive one, like you see on the middle screenshot. Once again, if the patient agrees to move forward with the second dose, we can assist them right there in scheduling an appointment and reminding them of that appointment 48 hours before the actual time. So I know that was a lot of information, but hopefully that gives you a sense of how Notable and intelligent automation can power the end-to-end workflow of vaccine administration and distribution for a health system. Now, a few things I do want to point out, and mostly on the right side of the screen, you'll see that all of what we've shown you today is configurable. Everything from the brand elements on the top, to the colors, to the clinical messaging itself, as well as the routing logic. So if a certain question needs to be framed in a different way, if an answer choice needs to dynamically route to a different pathway, all of that can be configured, and it can be configured extremely quickly. We also have a lot of institutional experience working with each of these EHRs in terms of integrating using robotic process automation and doing that in 4 weeks or less. Today, we're excited to announce that we're opening our initial cohort for enrollment to deploy this capability at health systems across the country. We can schedule a meeting as early as next week to demonstrate what a custom configured experience would look like for your health system and allow you to demo it on your own mobile device. And again, want to reiterate that the zero interface RPA integration allows us to integrate with your EHR or multiple EHRs within your system in 4 weeks or less from project scoping to kickoff. Undoubtedly, we're in a challenging phase of this pandemic, but also a hopeful phase as we look toward the next few months of getting the entire population, or at least the majority of the population, vaccinated. As Dr. Emanuel and others have pointed out, there will no doubt be many challenges, both operational, logistical, and technical, that health systems will be faced with as they take on this enormous task. But Notable, through intelligent automation, we truly want to be a partner and want to help throughout this process in using automation and technology capabilities to help offload your system and allow you to vaccinate patients in a more effective and safe manner. So with that, I want to thank you again for joining us today on this webinar, and excited to move into a Q&A to answer any questions that you may have. Thank you.
All right, everybody. By way of introduction, my name is Matt Cerna, and I lead marketing for Notable. And I'll be moderating a Q&A with Dr. Alagapan over the next 22 minutes or so. Unfortunately, Dr. Emanuel had to drop, but we have a number of questions that I think Dr. Alagapan should be able to answer. So I'll just start working through the list. So Dr. Alagapan, first question is around what are the algorithms or means through which it is determined who should get the outreach for the vaccine using this capability?
Great, thank you, Matt. So this is a great question. So we've designed the platform to be highly configurable and adaptable as algorithms change. You know, one of the complexities with vaccine administration is, of course, the tiered and phased approach of distributing the vaccine, as well as the ever-changing requirements and algorithms for which patients are now eligible to receive the vaccine, which we know varies by time, but also by local and state guidelines. So the way the platform is set up is that we can configure that algorithm extremely quickly, in minutes to hours, to instantly train all of our digital assistants on which patients are considered high risk or eligible to receive the vaccine at that time. So the short answer is we have an algorithm trained as is, and as the guidelines continue to change, we retrain our digital assistants to match the exact algorithm and eligibility criteria that your system or your local or state government needs to follow.
Fantastic. Great response. I think next question gets in a little bit around, we talked about a lot about how Notable automates workflows associated with COVID-19. Are there other specific workflows that are commonly automated by Notable? And how does it specifically work to automate those workflows within an EMR environment?
Yeah, sure. So Notable is an intelligent automation platform that automates workflows throughout the care continuum, spanning the administrative, clinical, and revenue cycle domains. Within that, our COVID vaccination flow is one of those flows as part of the broader intelligent automation platform, but there are many other automations that we currently have live with our customers. On the administrative side, we help health systems automate everything from appointment reminders to outreaches to patients who are due for care, as well as the pre-visit intake process spanning registration, check-in, clinical forms, patient-reported outcomes, and even consent forms. On the clinical side, we help providers automate many aspects of their workflow, including automating parts of the note, like you saw earlier with the history of present illness, automating common orders that they're likely to want for particular patients, as well as automating referrals and subspecialty consults. And then on the revenue cycle side, we've been able to automate payment collection and outstanding balance collection for payments both before and after visits, as well as insurance eligibility, notice of admissions, and many other workflows within that space. Again, our COVID vaccine automation is the latest automation within this broader intelligent automation portfolio. All of our digital assistants are trained to work across software applications and electronic medical records. So we've been able to use robotic process automation to integrate successfully and rapidly with all major EMRs and also practice management and revenue cycle software applications.
Got it. And just to confirm, because there's a number of questions about EMRs. So there's been questions about Epic, ECW, Cerner. Would you like to just go through a quick list of EMRs that Notable has successfully supported through previous deployments?
Sure. And many of our largest health system customers have 6 to 10 EMRs within their single health system that span multiple states. So this is a challenge we've kind of dealt and overcome very early in the history of the company, is being able to integrate with many of these disparate EMRs. So we've integrated successfully with Epic, Cerner, Allscripts, Athena, ECW, and many others, as well as practice management systems and revenue cycle systems. The digital assistants using machine vision are able to essentially seamlessly switch between software applications and EMRs, able to transmit data from one to another, and then also to perform tasks within a single EMR with a wide breadth of functionality, the same way a human being would use that electronic medical record.
Fantastic. Another question that came up. So as you know, a lot of different health systems serve different types of patient populations, and it's not uncommon for folks to speak patient populations where English is not the first language. How does Notable think about supporting other languages through its applications when it engages patients?
Yeah, great question. One of our core principles with automation is that we want to deploy automation in a way that improves equitable outcomes and overall opportunities, especially for those for who English may not be a first language or for disadvantaged populations. So we're constantly expanding support for new languages on the platform. We're able to build our automations and clinical outreach forms in any number of languages. And as I mentioned, we're consistently and constantly expanding support for those languages. And if there's any languages not currently on the platform, we're more than happy to discuss and make sure that we can support those patients as well.
Got it. And in a similar vein to making sure that all patient populations are supported, there's some questions that have come in around, what if patients don't have a smartphone, or seniors, for example, who may not be as proficient with something like text messaging. How does Notable think about engaging with those types of patients?
Yeah, that's a fantastic question. As a physician, one of the earliest things I learned was that a medication you prescribe is only as effective, for the patients who actually take it. And technology is no different. Technology is only effective for those who have the ability to engage with it in a meaningful way. So our platform, leverages technology in a multimodal way to reach patients. So we primarily use text message to reach patients of all age, but we also have support for email as well as in-person iPad or tablet support. So between those three modalities of text message, email, and in-person tablets, we've been able to reach over 95% of patients in many of our clinics, either before or after a visit. We've actually been really pleasantly surprised to find that even in older populations, those over the age of 70, our pre-visit completion rates are actually very, very high, where we have pre-visit engagement above 70%, even in age ranges where, traditionally it's thought that those patients may not engage as well with technology. The reason for this is that we've made our platform and the way we ask and approach patients with questions on technology to be as low barrier and as delightful and seamless as possible. So there's no application that they need to download from an app store. All of it is on a web app. It's easy and safe and secure to authenticate and to get started. So we found that to be really effective. We've also found that even patients with disabilities are able to engage using our technology platform. So, just a few weeks ago, we had a blind patient at one of our health systems complete an entire health risk assessment form using voice-over technology on an Apple device. So we're constantly adding technology support to make sure we can reach these disenfranchised populations. And with a multimodal approach, we've actually found that to be quite effective.
Fantastic. Another question on a slightly different tack. Can you just speak to Notable as it pertains to HIPAA compliance?
Sure. So, as a healthcare company, protecting patient information and information security is of utmost priority and really underpins everything we do and how we think about deployment and implementation and also outreach to patients. We have an entire, of course, information security team and process devoted to this, and we've been live with major health systems, including Intermountain and Common Spirit, for a long time, and have been able to cross those hurdles successfully in a way that both protects protected health information and make sure that we're as secure and compliant with information as possible.
Fantastic. There's another question. I think it's a really interesting question. I know this is one we've talked about internally. How does this capability work if the population isn't currently in the EHR? So I know that a number of healthcare organizations are, for example, getting lists of patients from state departments of health, or may not have this data accessible in the EHR. How would Notable approach that type of challenge?
Yeah, it's an interesting question. So we think about this as two ways to trigger an outreach to a patient. The first way, and actually the more streamlined way, is if we're given a list of patients that we want to outreach to. So whether it's a list that's derived from an immunization registry or a state or local government, or from some other organization, if we're given a patient list of MRNs or phone numbers or email addresses, we can feed that straight into the Notable platform and have an instant outreach to those patients via text, email, or again, an in-person or drive-through clinic experience. The second way that we can outreach to patients is we can have our digital assistants actually scan through your electronic medical record and identify which patients fall under the current eligibility criteria to receive the vaccine. So we think about this as the digital assistants searching through the EMR, finding the patients who are eligible, and then reaching out to them from there, where the bots or digital assistants have the intelligence to do that level of work. So either modality is fine. Either if we're given a list of those patients, we can feed it into the system and have the digital assistants perform the outreach, or the digital assistants can themselves, go and find the patients that are due for this type of vaccine, or frankly, for any other type of care. So we often deploy this type of solution when we're looking for patients who have a care gap. So if they're due for a colonoscopy, or they're due for a Medicare annual wellness visit or a shingles vaccine, our digital assistants are constantly uncovering those patients and those populations and then reaching out to them and keeping them engaged.
Fantastic. Another question, and this may be more of a health system policy question rather than a technology question, but I'm curious to get your thoughts on how technology could support. Is there a plan regarding communication to patients who continually refuse the vaccine? Or I guess put another way, how might technology be able to support continued education for folks who may initially be hesitant to move forward with vaccination, even if they are in a cohort that might benefit?
Yeah, that's a wonderful question. So the way we approach this is we first look at diagnosing the problem. So every time a patient tells us that they're not interested in receiving the vaccine or that they want to postpone receiving the vaccine, we can actually dynamically ask them follow-up questions on why that is. The follow-up questions can be unstructured text, simply asking them to explain their reasons for not wanting the vaccine, or we can ask follow-up questions in a structured manner to assess what the most common reasons are for someone not wanting the vaccine. We believe that diagnosis step is actually quite crucial since it'll help us understand what those reasons are and then help us solve or mitigate those reasons going forward. The second approach that we take here is that as a technology company, we have the ability to test different outreach approaches to see what is most effective in engaging with patients. So for example, we can try two different types of text messages to see if one is more effective at helping patients understand the importance of the vaccine than the other text message. Or within the form itself, we can frame the question in a certain way to see if it is more appealing or more engaging to patients. We can also do this with the time of day we send our outreach. So we may, and we have an entire data science team that studies this, but we may find that sending a text message on Thursday evenings is better than sending a text message on Friday mornings, or reaching out to patients, again, at a certain time of the week is more effective. So with those types of engagement experiments, we also have a better way to capture patients who may normally be reluctant. And then finally, we have a built-in process for re-engagement with patients. So if the patient tells us that they'd like to postpone the vaccine by 7 or 14 days, our digital assistants can automatically reach back out to that patient at a later date and can also continually provide engagement to the patient during that time in terms of, frequently asked questions, potential side effects, and other education to help slowly inform the patient of why getting the vaccine may be the right decision.
Phenomenal answer. And a follow-up on that, in addition to tailoring that testing and optimization across an entire health system's patient population, is it possible to configure the way in which the messaging or education is delivered to certain demographic groups based on how a health system understands different parts of their patient population to respond?
Certainly. We think this level of personalization to patient populations and to localities is of utmost importance. So we certainly don't want to be a one-size-fits-all solution, and that's why we've designed the solution to be highly configurable. In March and April of the pandemic, we began doing COVID screening, as we showed in the presentation, to screen patients for their symptoms to see if they're at risk for getting COVID-19. We've sent over 310,000 of those COVID outreaches to date. But the interesting thing I'll mention is that those COVID screenings actually looked very different from clinic to clinic and state to state. So in certain clinics where the patient population may be of a certain type, we were able to actually configure the questions and the way we did the screening to be more effective. Or if we found that certain symptoms were more prevalent in certain geographies, we could add those symptoms to the screening specifically for that locale. And our approach to the vaccine is going to be no different. We recognize there's a tremendous amount of heterogeneity between these different geographies and patient populations, and the platform at its core is meant to be configured so that it can be tailored to these patient populations from everything from the language to the text message copy to the questions themselves to the outreach scenario of where the patient needs to go to actually get the vaccine. So all of that is entirely configurable, and we do all of that in partnership with the customer and our customer success team.
Fantastic. Another question about how outreach as it pertains to text opt-in. So the question is text message outreach dependent upon patient consent or opt-in? Have there been privacy issues, or do these outreach texts take place only after we've gotten patient consent, or rather the provider has gotten patient consent to have texts be sent out?
That's a good question. So we offer the opportunity for all patients to opt out of the text message upon receipt of the first message. So they can text stop at any time to stop receiving text messages. With certain customers who prefer that we have an opt-in approach, the customers have obtained consent in an opt-in manner from patients before sending the outreach texts out. Or they may already have consent for opt-in based on other prior text message platforms that the system may have used in the past. So we've been able to work with either one. Either an opt-in or opt-out approach has worked really well on the platform. We've had customers who've taken both approaches, and we haven't run into any issues with, from a security or compliance perspective, using this approach.
Fantastic. All right, so we have 4 minutes left, and we have gone through a fair portion of the questions that we had, and we will need to be wrapping up soon. So I have one more available that I'll ask, and while I'm asking this, if folks have any other questions, feel free to submit them in the chat window. So there's a question around setting, and we hear this a lot. There's a question around how we're able to set up Notable so quickly without, or while working with or working around traditional EHR integrations. I recall, Dr. Alagaffin, you mentioned 4 weeks is how fast we've gone live with certain customers. Especially for folks who may not be as technical on the call, can you help walk through how that is and how Notable's approach is a bit different from other technology solutions that folks may have implemented?
Sure. So the core, underpinning of our technology platform is robotic process automation, or RPA. RPA has been very effective as an integration method in other industries, but is certainly lagging in healthcare. But we have specific domain expertise around building RPA solutions and also integrating them. What RPA is it's the ability to train digital assistants to navigate a computer screen using machine vision, and then to interact with that computer screen in both a read and a write manner, the same way a human being does. So you can imagine training a digital assistant to recognize a button on the screen that says, create a note, or using the digital assistant to type text into a note, or to check a patient in. So we have pre-trained our digital assistants on performing all of these common manual tasks across electronic medical record software systems. That allows us to go live extremely rapidly, anywhere between, a few days to 4 weeks, because all we need to go live is login credentials for that EMR. So if our digital assistants are granted a login credential, the same way you would credential a new employee that you're hiring, the bots can get to work in performing these manual tasks. They can work 24 hours a day, and we see that integration be extremely rapid. If there are places where we can leverage APIs or other methods of integration, we certainly will. But we recognize that APIs don't always exist for the types of tasks that we want to perform. And sometimes even when they do exist, the integration timelines are simply too long to be relevant, especially for time-sensitive matters like the COVID vaccine.
Fantastic. And then we have time for one more question, and then there's a number of other questions that have been asked that were more personal in nature in terms of, it depends on the customer, and so we'll reach out separately for those on a one-off basis. The last question, I think we have about 30 seconds, is does it matter how many unique patients are in the EHR system? Are there any limits on how many patients Notable can process?
There are no limits. We've worked with health systems, again, with footprints in, 10 to 15 states with thousands of providers, hundreds of thousands of patients. So really no limit. Again, we're able to scale up our digital workforce or the digital assistants to take on the number of patients that the system may have. So certainly not a concern, but a very good question.
Fantastic. Well, I believe that is all of the time that we have for today. Again, Dr. Gallo-Gappen, thank you for staying on after to answer all the attendees' wonderful questions, and I will pass it off to the Becker's team to conclude the webcast.
Thank you all again for attending today's webinar. Again, any questions that were not covered during the Q&A, Notable Health will follow up shortly here. Thank you all again and have a good rest of your afternoon. Bye-bye.